All right, so today I'm going to be presenting on the National Viral Hepatitis Elimination Plan. Again, my name is DeWayne Davidson. I'm an ambulatory care pharmacist at University Health. I'm also a manager at University Health, and I'm also a clinical assistant professor and pharmacist with UT Health San Antonio in the Department of Family and Community Medicine. I don't have anything to disclose. Next slide, thank you. So just want to give you a little bit of background on hepatitis trends in the United States from 2014 to 2018. As you can see here, a huge increase in hepatitis A cases. It's increased by 850% since 2014 to 2018. Hepatitis B wise, we're doing okay. I wouldn't say we're doing great, but it's only increased 11%. And hepatitis C acute cases are increasing by 71% over that time period. As of 2016, 3.3 million people in the United States are living with chronic viral hepatitis. This is broken down mostly hepatitis C, 2.4 million. And then hepatitis B is over 800,000 people in the United States. Next slide. So kind of circling back, the Viral Hepatitis National Strategic Plan, they've been coming out. This is the third one that's come out, but we've got a new one here for the 2021 to 2025 time period. It's a roadmap to elimination. This most recent one was released by the Department of Health and Human Services in early 2021. And really, it provides a framework for how we're going to eliminate viral hepatitis in the United States by 2030. And what do we mean by elimination? This is pretty hefty goals here, but a 90% reduction in new chronic infections and a 65% reduction in mortality compared to our starting point in 2017. So here we are 6 years later, 3 years after this roadmap came out. The question is, how are we doing? Next slide, please. So when we talk about hepatitis A, again, this is where we saw the 850% increase. We're not doing very well here when it comes to hepatitis A infections. You see there's a big spike here starting in 2017, going up to 2019. We really don't know the causes for this, but we do know that hepatitis A is transmitted through food sources, and we have seen in the news, even more recently, cases of hepatitis A being transmitted through lettuce, spinaches, foods that come off of certain farms. And so we're going to see more cases of this like we are seeing now. Obviously, there's a little downtrend here, but hopefully we can continue on reducing hepatitis A transmission in the community. Next slide. Again, hepatitis B overall doing pretty well. This is on a downward trend. So you can see we're reducing estimated new hepatitis B virus infections by greater than 20%. So we're on target for this one for the 2025 goal, as well as reported new infections among patients with that use injection drugs. Not doing so good in terms of reducing hepatitis B related deaths or in certain subpopulations such as Asian and Pacific Islanders. But again, not way off the mark here like we saw in hepatitis A. So just some things we need to work on and continue working on. Next slide. Hepatitis C, on the other hand, see this is where we're getting a trend on the upward slide, unfortunately. So here we have estimated new hepatitis C virus infections reduced by 20%. We're not really making it. And like I said, you can see here on the right-hand side, how it's just continually going up over the next years. Same for new hepatitis C infections among those that inject drugs. Again, not the downward trend that we are really wanting to see. However, on the larger picture, we are seeing some downtrends in hepatitis C related deaths. This may be due to having access to direct acting agents that will help eliminate hepatitis C. So in those respects, we're making some progress. Next slide. So what are some of the challenges we're running into, or that's identified here in the strategic plan for eliminating viral hepatitis? Certainly, missed opportunities for prevention through child and adult vaccination. I think one of the great things that's happened in the past year, 2 years, is hepatitis B vaccination for everybody now. It used to be select groups of people. Now it's for everybody. Lack of awareness of infection. Again, I think having screening tools and recommending screening has been really important in terms of making sure that we know who has hepatitis B or C and getting treatment for it. Testing and diagnostic limitations. We'll address this towards the end, but it is a little bit difficult for patients to get a lab done, because it's really the only way we can detect this. We don't really have any ways via saliva, urine, some easier methods. And so it really requires a blood draw in order for us to screen patients, which there is some hesitancy around that. There's also barriers to accessing care and treatment. So if you live in an area that doesn't have access to care, which is one of the reasons why ECHO got started in New Mexico, where treatment and access were limited, this can be an overall barrier. Limited data is kind of another reason. We don't have all the data we need to kind of track this, but we're working on methods to help increase that. And then just there's other things that go along with hepatitis. Hepatitis virus transmission doesn't always occur by itself. Sometimes it occurs in transmission with HIV transmission, or with sexually transmitted infections, or even substance use disorders. So oftentimes it comes along with other coexisting or coexisting morbidities. Next slide. So from the strategic plan, what's the overall plan and vision and goals? So really the vision is 3 parts. Basically here is to prevent new infections. Part 2 is making sure that everybody knows their status, so getting screenings done. And then 3, making sure that every patient has access to high quality care, so we can get treated and also prevent ongoing transmission. Goals here are listed here on the right-hand side. So again, prevent new viral hepatitis infections, improving health outcomes, reducing health-related disparities, increasing surveillance, so we can kind of see if there are new pockets or populations that are being more likely to have hepatitis B or C or even A, and then just achieving an integrated, coordinated effort to bring all the people together. And I think that's one of the great things about ECHO, is that this is kind of the forum for that. We're bringing clinicians, specialists, community health workers, all sorts of different organizations and places where you guys work all together, so we can all talk about this and have a coordinated plan to reduce hepatitis transmission and infection. Next slide, please. So something else in this strategic plan is this holistic approach to the syndemic. This is the first time I actually heard about the syndemic. We've heard about pandemics, epidemics, but this new term, syndemic. So syndemic occurs when health-related problems such as viral hepatitis, HIV, sexually transmitted infections, substance use disorder, and social determinants of health occur in the same area or in a cluster by person, place, or time. So this is kind of an interesting concept, how these things can all occur together. And so that may be a new way that we need to tackle, or we are actually kind of already tackling this in that particular way, but having a better understanding about this will be important. So as part of the plan, so elimination requires a holistic approach, so multiple services at the same location, so co-location of infectious disease plus hepatology, even primary care, will help cross-cut some of the barriers that are out there. Instead of having to go, to see one specialist, I can have care all in the same place. Cross-training staff, again, I think it's a major tenet of ECHO, is to cross-train staff that may not have normally been in a situation or position to be able to treat hepatitis C or B, but now be comfortable to do that. I think primary care is a great example of this, where we're cross-training medical professionals to diagnose as well as treat. And then the last thing is to provide linkage to care and patient navigation services across programs. So we're not duplicating services, but we can get the patients to the right place at the right time and be successful in the utilization of resources. Next slide. So this is a really great map that was it's from the Office of Infectious Disease and HIV/AIDS policy. It's just kind of looking at where there are programs that are trying to tackle hepatitis elimination. You can really see here on the South Texas orange zone, this actually stemmed from this program that you're currently a part of now. This was part of the Tackle HIV/HCV Co-infection in People of Color AHRQ grant. So as a lot of the people on this call that are still with the program were part of that founding group to really get this project going here in South Texas. But not just here in South Texas, you can see here across the United States of where there are states, county or citywide levels of trying to tackle this, as well as clinics or health systems that are also trying to tackle this throughout the United States. Obviously, a lot of activity happening on the Northeast portion of the United States and some in the Midwest, got pockets in the South and a little bit out to the West, but there's still a large swath of the United States where this is not even looked at yet, unfortunately. So we still need to do a better job across the board in terms of, how can we get this out to all communities across the United States that really need it. Next slide. This is just to kind of talk about, our original tackle program. Sometimes if you've been with us, you may have heard us call this Project Tackle, but we've moved away from that. But it really was the tackle program was a mnemonic for targeted access to community knowledge, linkage to treatment and education for HIV and HCV co-infected patients and people of color. It was a HRSA-funded project, really helped us get ECHO on the map here in South Texas and San Antonio. We're now an ECHO hub, and so this is kind of the starting point for how we've branched from this HIV, HCV co-infection now to individual programs for HCV, also ones for HIV, and other programs that we have here under our ECHO umbrella at UT Health San Antonio. Next slide. When it comes to the National Hepatitis C Elimination Program, this is something that has been proposed in the Biden-Harris administration budget for the next fiscal year. It's a 5-year program to eliminate hepatitis C in the United States. Again, it really hits on a lot of the points in the framework for elimination. So the goal here is to expand screening, testing, treatment, prevention, and monitoring of HCV infections, really focusing in on high-risk population. It has 3 main priorities. Now, you guys, as we're currently, in our political environment, the budget still hasn't been passed. There's still some negotiation between Congress and the president in getting these things, but this is still there. So hopefully, we'll see this pass in this year's budget because this is a high priority area. Next slide. So the last part here, we're just going to talk about the 3 main priorities that are found within that budget. And the first one is point of care testing. Right now, there is no point of care testing for hepatitis C. Like we do for HIV or even diabetes, flu, even pregnancy testing are all point of care tests that you can, within the same visit, have an outcome and know, my patient has this particular condition and needs to be treated. So I think this would be a really great boon to eliminating hepatitis C, and to think, just to go beyond, typically think about point of care testing in our clinical offices, but point of care testing can happen in various places, including pharmacies. So just a little plug for my pharmacy profession, we can do point of care testing and get patients linked to care quickly too, because we're very accessible. But it eliminates testing and starting treatment, or it eliminates testing and starting treatment in 2 different visits. So now you can have those both occur in the same visit. There are countries that it's available outside the United States. We're not there yet, but hopefully we'll have something here soon in the United States, but it'll also help having this in the budget and as a priority will help clear approvals for point of care testing in the United States through the FDA, like it was done for the COVID tests. Next slide. Next priority is access to direct acting agents. Again, these things are very expensive still to this day. They're starting to become generic here in the next year or so. I think Epclusa is now generic, and if not, it will be soon. But really, it's the cost of these can be really prohibitive for patients that don't have insurance, but as well as to healthcare plans. So if there are ways where the federal government can purchase these drugs and dispense them where necessary and eliminate that cost, that'll help get treatment into patients' hands that really need it, that can't afford it. I know there's a lot of organizations out there that utilize their 340B cost savings to really help with this. Still, it's expensive, but it does help offset some of the cost. But here again, providing copay assistance to Medicare beneficiaries. Unfortunately, if you have Medicare, you can't use copay cards, which people with commercial insurance can. And so again, it makes it difficult for patients with Medicare. If they're in the donut hole, they have to pay 25% of the cost of these medications. And when you're talking about $10,000 for a treatment, it's going to be almost impossible for a Medicare patient to come up with $2,500 for their portion of this if they're the donut hole. And then again, encouraging private insurance to also help cover the costs of treatment and testing. Next slide. And the last thing here, priority number 3, is comprehensive public health effort. Again, here, ECHO is kind of a piece of this. It's a part of a larger portion to eliminating hepatitis C in the community, but it really needs to be a coordinated, comprehensive effort really to support universal screening as part of routine care, which we do have that now. So we do say hepatitis C, everybody at this point should be screened for it. Seeking to diversify testing locations. So again, like I mentioned, pharmacies, doesn't necessarily have to happen in a physician's office. Building infrastructure for scale up, and that's why we have this ECHO model. Really, again, it stemmed from, if you're not familiar with the ECHO model, it stemmed from hepatitis C treatment in New Mexico, where a hepatologist in Albuquerque can't reach everybody in South New Mexico, and you don't have hepatologists or gastroenterologists in those areas. And so they're relying on this model to teach and train primary care physicians to be able to treat hepatitis C in New Mexico. And that's why this really became successful as a model and why we're promoting this across the United States. The last couple things here, just supporting community access sites, including federally qualified health centers to use, care managers and community health workers, again, linking patients to care, and then re-energizing vaccine research. So again, if we can prevent hepatitis C infection like we do for hepatitis B, that would also be a boon to reducing hepatitis in the community. Last slide. So just to summarize, viral hepatitis is a significant public health threat. And despite the availability of effective clinical interventions, new and acute viral hepatitis infections have increased in recent years, and we still have a ways to go in order to get this under control. Last point here is the continued innovations and implementation of highly effective prevention and treatment strategy with political will and strong community engagement are key to achieving the elimination goals. So getting all of our politicians on the same plane here, that we're all trying to do this for the better of the public health and public good. We need to do this because it benefits all of us. And that's all I have. Any questions?